So the good thing about this talk is that you don't really have to memorize or really think too much. If it's too complicated, I try to make it some board-oriented talk. But some of it is going to be obviously not in clinic yet, but I would try to give the gist of it. So this is a critical figure for immunity. So the critical point here is that against the virus or antigens or transplant antigens, typically the immune cells, which consist of T cells or B cells or NK cells, these are subtypes of immune cells, they don't directly interact with the antigen. So they need to see the antigen in the context of a bunch of other molecules presented by these cells, which are called antigen-presenting cells. So, and that's a very important concept in immunology, not just transplant immunology, in immunity against virus, immunity in settings like diabetes, rheumatoid arthritis, the sort of autoimmune type of diseases where this circle here could be, for instance, a peptide of the virus. It could be a piece of peptide coming from a transplant organ, or it could be a tumor antigen event. So these molecules are always presented to the T cells in the context of a bunch of other molecules. And what is important to note is that the outcome, which is basically here is shown by how much these round-shaped cells are actually the immune cells are literally chewing this muscle, which is a heart transplant here, right? So, or in this case, is a type 1 diabetes where these are immune cells that are invading this round-shaped islet, which is producing insulin. So the net outcome or pathology here is always infiltrates. But these immune cells are always educated here in the lymphoid tissue, and then they get all the lessons and they know where to go to invade the organ. So the education takes place in the lymphoid tissue. They know, they get the zip code, basically. They're instructed with what to do, and they go back to the transplant organ, cause rejection or diabetes, infiltrate the islets, or actually in the case of tumor, they attack tumor. There are two series of molecules. So if you let the immune system or immune response goes unleashed without any control, they're going to have a cytokine release. And typically patients die of actually pulmonary edema. And if you see more and more data on patients who have excessive leakiness of the vasculature in a setting of cytokine release, is always, if you look at the autopsy of their lungs, always you see bleeding and excessive hemorrhage in the lungs, which is thought to be because of the increased permeability of the capillaries. And you see this so-called cytokine release. Used to be when the rejection drug came by the name of OKT3, which was a drug which would kill all the T cells. The initial complications were seen with that classical drug were pulmonary edema and fever and systemic release like low blood pressure, like a sort of septic shock type of feature. So therefore, body has the molecules that try to control this immune response. So if you have your body's fighting against virus, or your body fighting against a transplant antigen, or whatever, like a peptide, lupus nephritis or type 1 diabetes, you have your immune system acting against your own antigens. There got to be some sort of negative pathways which say, okay, now you have to turn it down, the virus is cleared. If you look at the transplant organ after full rejection, when the creatinine goes to 6 pre-dialysis, the immune response actually, as the tissue dies, the immune response goes down. So those pathways are called negative pathways. And the ones that actually give extra boost to immune response to have more immune activity are called positive molecules. And believe it or not, so the negative ones always turn down the immune response, and positive ones further augment the immune response. Whatever in transplant we do in order to increase tolerance, acceptance of the organ by lowering the immune response, because we use immunosuppressive drugs like calcineurin inhibitors, like tacrolimus, or steroid is that you, at the same time, increase risk of cancer, right? Because the same immune response, immune cells that invade the organ, they actually work nicely to find out the tumor. So the tumor immunity is heavily driven by the same immune cells that look around all the time. And there are sites that you see the new tumor coming with new antigen, they're gonna detect them and basically reject them. So whenever you use immunosuppressive drugs in these patients, risk of cancer goes up, and you're gonna hear more skin tumors, like in Australia, majority of patients who are gonna be having sun exposure, they're gonna have skin cancers. Or classically, it's called PTLD, which is a post-transplant lymphoproliferative disorder, and has to do with lowering your immune response, and you're lowering your tumor immunity, right? So that's the balance that we always deal with in terms of the immunosuppression, and there is no clear cut technology or approach to figure out who should be, where we should keep our level of immunosuppression. You always put the immunosuppression and the patient start having a sort of skin cancer or PTLD, post-transplant lymphoproliferative disorders, you start cutting the immunosuppression. So, but the immune cells are, I don't want to confuse or make it too complicated at this hour because you guys are tired, but you may hear more and more that the immune cells, which are T cells, they're classified in different ways. They're called, for instance, after activation with by dendritic cells, they're going to be, for instance, here it's called Th1 cells, or you may hear this actually may come actually in internals of book, because these are not any more advanced immunology, and it has to do with the type of cytokines they produce. So when the immune cells get activated, they differentiate and they produce different form of cytokines, and they play different roles in different diseases. For instance, this type of cell, which is called Th1, which produces interferon gamma, is a bad type of T cells for graft rejection, but this one is actually promotes asthma. So shifting toward a specific immune response or different cytokines, the outcome is going to be different diseases. So this is the critical figure. So whenever you have, again, an immune response against the antigen, you're going to have increased activity of so-called effector immune cells. At the same time, you're going to have immune type of cells or molecules that are going to turn it down. And the balance is extremely critical here, which is between aggressive cells and the same time cells that we call them regulatory T cells. These are the cells that actually activated, but their role is not to destroy the organ. Their role is actually to prevent graft rejection. So whenever T cells get activated, they're going to have two sets of T cells that are going to go reject the organ. At the same time, you're going to have activated T cells with the property to turn them down. So the balance in terms of tolerance is that whatever you do or therapies that you're going to give to these patients, if it promotes more of these so-called Tregs, the chance of tolerance increases. And I'm going to show you some of the strategies that people or new therapies in order to promote these sort of cells in transplant. So classical immunosuppressive drugs actually could be classified in two groups. One of them is so-called maintenance therapy, like patient is going to be like a steroid. I'm sure you all gave a steroid for whatever reason, for asthma, for rheumatoid arthritis, gout. That is a classical immunosuppressive drug, and lupus patient is going to be on it for many years. That's called maintenance. There's another class of drugs that we give. They're called in the induction group. It's very much similar to chemotherapy drugs. You come with a massive amount of drugs at the beginning, then maintain the patients on maintenance drugs. So the induction, which you hear I think tomorrow, it consists of the drugs that wipe out the T cells. They don't change their function. They basically deplete them. These are depleting agents, and obviously they're heavily immunosuppressive drugs, and the risk of infection goes up. One of them is called, for instance, thymoglobulin. Is a is believe it or not, there's a farm of rabbits that you infuse thymus of the human, and the rabbit produces antibody against the thymus of the human. You get that antibody, and it's called thymoglobulin. It's a very famous medication. Is used all the time for renal transplant patients. You give few doses of that drug in post-transplant. It lowers your T cells to level very, very low, and then you come and put the patients on the immunosuppressive drugs like Prograf, Cellcept, or prednisone for the rest of their life. But that induction allows you to be able to play around with the dose. So if for a few days the Prograf level is going down to, let's say, 2-ish, which risk of rejection go up, because initially post-transplant you want to keep the level of the drugs high because the risk of rejection, acute rejection, is very high within first 6 months post-transplant, is that induction allows you to maneuver, to play around with the maintenance drugs. For almost Brigham is historically, obviously, I don't know how much you know, but was the first place that kidney transplant was done in 50s. And that time there was no immunosuppressive drugs, but they were able to succeed was they found a twin. There was identical twins, so kidney came from brother, and there was no need for immunosuppressive drugs. But before that, actually, in France, they used to do transplants, and some of them would last for a few months, but the kidney would stop, and they didn't know what to do. But there was no immunosuppressive drugs that time, in 30s. The early class of immunosuppressive drugs one of them was called Imuran, azathioprine, was a classical drug, and obviously prednisone were there, and it led to some success using kidney organs from unrelated donors. Then the new drug came called Cyclosporine, which was again started at Brigham, is a very potent drug which alters the function of T cells. It binds to a molecule in the T cells, prevents T cell activation. Again, this drug is not a depleting agent. It changes the function of T cells. And majority of transplant programs, I would say more than 90% programs, now use Cellcept, which is a newer version of the azathioprine, right? Tacrolimus, which is a new version of cyclosporine, and they get induction, which is a thymoglobulin. I would say 90% of the protocols basically consist of thymo beginning, then putting them on Prograf or tacrolimus, and Cellcept, and thymo allows you to stop prednisone after 5 days. Most programs try to withdraw a steroid because of the complications. These are the classical immunosuppressive drugs, which we use all the time. And obviously, you heard about toxicity of the kidney because of the Prograf, and up to 30% of cardiac transplant patients, for instance, end up being on dialysis. It's a huge number. If you look at these patients, it's unbelievable that they get cardiac transplant, they end up on dialysis probably because of the huge amount of calcineurin inhibitor Prograf that are used. And if you go, and the level that we shoot is not universal. So it could be program, you want to run the Prograf level, for instance, for 7. Cardiologists actually may run at level around 13. And 13, if you do it in rabbits, if you run that, you can shut down the kidney. So the long-term complication of these drugs are very well known. The most common reason of death in these renal transplant patients is not kidney failure, it's a cardiovascular disease. They die of cardiovascular disease. It's probably one of the most accelerated form of cardiovascular disease seen in solid organ transplant. Why? Because they come with having all the risk factors for high lipid, blood pressure for years, and then you put them on these drugs, which are immunosuppressive drugs, which increase lipid, for instance. Notoriously increases your lipid, increases blood pressure. Calcineurin inhibitors, prednisone increases blood pressure. So then you add up way more risk factors to the kidney, to the heart, and they die of heart disease with functioning kidney. So the trend now is to figure out a way to reduce the amount of these drugs we use and bring newer drugs which are safer. And class of drugs that are going to be more and more be used is one of those is drugs that are actually going to be pulled from rheumatoid arthritis. So believe it or not, pharma loves rheumatoid arthritis for their own trials because you have tons of those patients, You can do trials very fast. You can look at a bunch of mobilities of joints and here and there, come up with scales and publish them very fast, and pharma loves it. So doing such a study in transplant is going to be very complicated because toxicity is high, these patients are immunosuppressed, and if one patient dies of infection, then they're going to have, they're going to be very sensitive about it. So the anti-inflammatory drugs that are used for instance, rheumatoid arthritis, like anti-TNF is one of the most expensive drug, or anti-IL-6. Those drugs are going to be more and more used in transplant because inflammation is a major problem in transplant. When I say inflammation, a lot of people say, well, inflammation is like a joint inflammation, like rheumatoid arthritis inflammation. So this is a very vague term if you think about it. In the community, in the medicine community, inflammation is always considered as like a sort of peripheral type of manifestation of like some sort of arthritis. But in a more specific term, inflammation represents all the activity of all the molecules which within the organ. Remember, when the earliest sign of inflammation in the kidney transplant is seen as actually right after brain death. Before even touching the kidney, right after brain death, you have increased inflammatory molecules in the kidney. And it's thought to be because the brain controls the expression of those molecules. And how brain controls it, this is actually one of the hottest topics now, that how neuro impulses control immune response in different places. So you're going to have increased inflammatory responses in the kidney shown by increased level of cytokines and all these things in the kidney. And then when you remove the kidney, every organ transplant experiences ischemia reperfusion injury, right? And the average cold ischemia time, meaning that the time that you get the kidney from different places, transplant, is about 6-7 hours. A living donor is about 40 minutes if you're a good surgeon, right? So if you look at the rate of rejection rate and the cold ischemia time, longer cold ischemia time rate of rejection is higher. Why? Because the ischemia increases inflammatory responses in the kidney, and that actually increases rate of rejection. So medications going to control those kind of inflammatory responses, like anti-IL-6 and anti-TNF, going to be used in transplant. Obviously, you're not going to use NSAID because a lot of people, when we say anti-inflammatory drugs, you normally think about NSAID, but obviously we're not going to use NSAID in these patients, right? So more targeted anti-inflammatory drugs going to be used. Why? Because the toxicity, cardiovascular toxicity, tumor, those sort of things are quite high with classical immunosuppressive drugs. Here is another one, TNF, which is anti-TNF for renal transplant patients. You will see it. This drug is already in a clinic now. It's a newer drug. It's called Blataseb. Again, where it works at the level where I say that there's a positive kick to the T cells that push T cells to become more active. It hits right there, and it says, well, I want to prevent that T cell activation. And this is a drug that is shown to improve the safety profile of immunosuppressive drugs, because then you can now lower your prograph. Now you can lower calcineurin inhibitors, which are known to cause microvascular toxicity. How much time I have? 4 minutes. Good. Okay, so another cutting-edge way of doing it is that how we can deliver drugs to specific sites. So, you have the liposomal version of the antibiotics now, right? Because it prevents kidney toxicity from amphotericin type of experience that's been around for years. So we're going to see more and more how we can package these immunosuppressive drugs with different particles to deliver to specific sites. Cell therapy is going to be coming to transplant. The cells that I said, they're going to be sort of suppressive cells that turn down the rejection. Whether we can isolate those cells from a person and enrich the good T cells and send them back to the patient. That's called regular T cells. probably so this is the critical part. So this is a so-called tumor immunity. These are the immune cells that recognizing a tumor. So if you obviously give immunosuppressive drugs, risk of tumor goes up. That might come up your board. I mean, they're going to always ask about PTLD, which is a post-transplant lymphoproliferative disorder. It's a B-cell type of tumor that happens in these patients. This is good. This is something that is out there, 3D printing. You can basically get the stem cells, put them in scaffold that's meant to support these cells. The idea is that actually Joe is actually one of the leaders in the field, is that the organ transplant is obviously a life-saving strategy, but can we get the cell from the patient, grow them, make new kidney and put them back, and then you don't need immunosuppressive drugs. Then you don't need me come here and tell you about complication of immunosuppressive drugs. So these are all the platforms out there that allows you to culture the cells, shape them, and 3D printing is actually, you can tell the printer to the dynamic and physical characteristics of the organ, and you can actually shape the entire organ, and you can come back and culture those scaffolds with different cells. So immunosuppressive drugs are toxic. Obviously, they're critical. They're necessary for transplant success, infection, cardiovascular mortality, tumor. The trend nowadays is to be able to reduce those toxicity by bringing new, safer drugs, primarily anti-inflammatory drugs like anti-IL-6. Cell therapies are out there, and 3D printing. Maybe you'll hear in 10 years that it works in human.